part of the class, sir.
Yeah.
Dr. Sanjeev Raju from JRH, he will be presenting the answer for the question, theory question, fetal well-being monitoring and neonatal resuscitation. Over
Okay.
to Dr. Sanjeev Raju from JRH.
Good evening, everyone.
Good evening.
Sir, today my topic of presentation is monitoring of fetal well-being and neonatal resuscitation. Okay. Sir, shall I start?
Yeah, please go ahead.
Yes, sir. All the pregnant women should receive the regular antenatal care throughout the pregnancy, and fetal well-being should be evaluated at every visit. The goals of the fetal monitoring are early identification of the fetus who are at risk of preventable neurological injury or death. Many tests have been developed to identify the fetus at risk and for at risk. So there are many tests which are being designed to assess this. They are non-stress test, biophysical profile, contraction stress test, CST, vibroacoustic stimulation, Doppler velocimetry, and fetal movement chart or kick count, fetal kick count. First one, the non-stress test or NST. It is non-invasive, simple to perform, inexpensive and readily available test. It usually measures the changes in the fetal heart rate with time. It reflects the maturity of the autonomic nervous system in the neonate. So it is not useful in the preterm neonate, that is for child neonate less than 28 months. This test is usually performed before the onset of labor for a period of about 20 to 40 minutes, and the recordings are noted on a strip. The strip moves at the rate of 3 centimeters per second. The fetal heart rate is determined externally with the use of Doppler ultrasonography, and it is so recorded on a strip. The presence or absence of uterine contractions is recorded at the same time using external tonometer. This tonometer records myometrial tone, timing, and duration of uterine contractions. The results of the NST are given as reactive or non-reactive. Reactive NST is said to be reactive if there are 2 or more accelerations that peak for which have at least 15 beats per minute for 15 seconds in a 20-minute time period. For a preterm neonate, the NST is said to be reactive if there are 2 or more accelerations that peak for 10 beats per minute for a period of 10 seconds over a total of 20-minute interval. A reactive NST is regarded as the evidence of health. The terms which are used in a non-stress test are accelerations and decelerations. Accelerations is defined as heart rate which is above more than 15 beats per minute above the baseline for 15 seconds but less than 20 minutes, less than 2 minutes. And prolonged acceleration is defined as acceleration which is lasting for more than 2 minutes but less than 10 minutes. And decelerations, there are 3 types of decelerations. They are early, variable, and late. In early deceleration, the beginning, peak, and recovery of the deceleration coincides with the contraction of the uterus. It is due to increased fetal intracranial pressure causing raised vagal tone. The second one is variable deceleration. This is decrease in the fetal heart rate of more than 15 beats per minute below the baseline and lasting for more than 15 seconds but less than 2 minutes. The variable decelerations are seen due to umbilical cord insufficiency. And late decelerations, here the onset, nadir, and recovery of the deceleration is which occurs after the uterine contraction. This is seen in the uteroplacental insufficiency. Then second test is vibroacoustic stimulation or VAS. It refers to the response of fetal heart rate to vibroacoustic stimulus. Here, sound of 82 to 95 decibels is applied to the maternal abdomen for about 1 to 2 seconds in the region of the fetal head. The acceleration in response to vibroacoustic stimulation is a sign of fetal health. This test may be repeated up to 3 times for progressively longer durations up to 3 seconds. This VAS test is a useful adjunct to achieve the reactive NST, and this test has no adverse effects on fetal hearing. The third test is biophysical profile. NST alone is not sufficient to confirm the fetal well-being. In such cases, biophysical profile is performed. It combines NST with ultrasonographic scoring system, which is performed over a 30-minute period. It has the following parameters: gross fetal body movements. It has 5 parameters. Biophysical profile contains 5 parameters. They are gross fetal body movements, fetal tone, fetal breathing movements, amniotic fluid volume, and NST. Gross fetal, the scoring is given as 2 if the movements are present, or 0 if the movement is absent. The gross fetal body movements are taken as at least 3 body or limb movements. If they are present, scoring is given as 2. If it is not present, scoring is given as 0. In fetal tone, at least there should be one episode of active flexion and extension of the limb. This is given as score 2, and if it is absent, then score 0 is given. Then coming to fetal breathing movements, at least one episode of breathing movement lasting for more than 30 seconds should be present. This is given as score 2, and if absent, given as score 0. Then coming to amniotic fluid volume, it should contain at least one pocket that should measure more than 2 centimeters. If present, it is given as 2, score 2, and it is absent. If absent, score 0. And then in coming to NST, if it is reactive, score given is 2, and then if it is non-reactive, score given is 0. And the total score is calculated. It is total is 10. If the total score is 8 to 10, the biophysical profile is known as reassuring. If it is 6, it is termed as equivocal. 4 or less than 4, it is abnormal. 0 to 2, it is non-reassuring. The management differs according to the biophysical profile score. If the score is 8 to 10, no intervention is needed. If the score is 6, the biophysical profile test should be repeated in 4 to 6 hours. And if consider for delivery, if the patient has oligohydramnios. If the score is 4 and gestational age is more than 36 weeks, we can deliver the patient. And if the gestational age is less than 36 weeks, repeat the biophysical profile after 4 to 6 hours. If the score is 0 or 2, then patient should be evaluated for immediate delivery. There is another parameter called modified biophysical profile. It has the following components called NST. It has following components. They are NST and amniotic fluid index. It is reactive. Modified biophysical profile is reactive if NST is reactive and amniotic fluid index with a maximum vertical point of more than 2 centimeters. It is abnormal if NST is non-reactive and amniotic fluid index is less than 2 centimeters. Then coming to the fourth test, contraction stress test. It is also known as oxytocin challenge test. This assesses the response of fetal heart rate to uterine contractions induced by either IV oxytocin or nipple stimulation. It requires minimum of 3 contractions for at least 40 seconds in a 10-minute period to interpret the test. It consists of the readings are given as negative contraction stress test. It means that there are no late or severe late decelerations with the uterine contractions. Negative CST means the fetus is healthy. Then positive CST, it means the late or severe it means the presence of positive late or severe late decelerations with at least 50% of the contractions. This positive CST suggests that there is a maternal to fetal oxygen exchange impairment during the uterine contractions and is associated with adverse outcomes. Then there is equivocal CST. It is defined when fetal heart rate decelerations occur with contractions more frequently than every 2 minutes. Then there is equivocal and suspicious CST. It is defined when there are intermittent late decelerations or significant variable decelerations. And CST is termed as unsatisfactory if there are fewer than 3 contractions in 10 minutes or if fetal heart rate is untraceable. This contractions test should be done in a in-hospital setting as there is a risk of precipitating the fetal compromise requiring emergency C-section. The contraindications to CST are placenta previa, abruptio placenta, and prior classical cesarean section delivery, and the baby who is at risk of preterm labor. Next, coming to the next test, which that is Doppler velocimetry. This is a non-invasive method of measuring fetal circulation, which which includes measuring in umbilical artery, middle cerebral artery, and ductus venosus. Measuring of use of Doppler velocimetry in umbilical artery. Umbilical artery is one of the few arteries with diastolic flow. The resistance to the blood flow from fetus to placenta falls progressively throughout the pregnancy. The factors that increase the placental vascular resistance are increasing gestational age, placental location, placental abruption, preeclampsia, and chronic hypertension. The decrease in diastolic flow with increased systolic to diastolic ratio suggests that there is an increase in the placental vascular resistance. Severely abnormal Doppler, that is absent or reversal of the diastolic flow, is associated with poor perinatal outcomes. A delivery is recommended if there is absent umbilical artery end diastolic flow after 34 weeks or if there is a reversal of end diastolic flow as early as 28 weeks of gestation. Then coming to the middle cerebral artery Doppler, this Doppler of middle cerebral artery can evaluate if there is an increase in cerebral blood flow in response to hypoxia. The cerebroplacental ratio, this is the ratio of middle cerebral artery pulsatility index with umbilical artery pulsatility index. In patients with abnormal umbilical artery Doppler, ductus venosus Doppler velocimetry may prove the predicted risk for hypoxia and stillbirth. Middle cerebral artery peak systolic velocity. It helps in evaluating the fetal anemia. If there is severe anemia in fetus, blood is preferably shunted to the vital organs such as brain, increasing the middle cerebral artery peak systolic velocity. And then coming to the fetal movements count or fetal kick count. The appreciation of the fetal movements is termed as quickening, which is reported at 18 to 20 weeks in case of nulliparous women and in case of from 16 to 18 weeks in case of multipara women. Most patients with healthy fetus exhibits around 10 movements in approximately 20 minutes. If there is a failure to appreciate 10 fetal movements in 2 hours, then immediate fetal assessment should be done. That's all, sir, regarding monitoring of fetal well-being.
Very good. That's an excellent presentation for knowledge sake. If you are going to write everything in your theory answer paper, you are going to write only this question alone to complete your answer. So
Okay,
you must be able to abridge it and try to present it in a shorter way. Anyway, you have, another important point is you have dealt mostly with the intrapartum monitoring of the fetus. Am I right?
Yes,
after
sir.
the contraction, after the labor has started. But if the question is worded as fetal monitoring, generally, it should start right from the time of the early gestation itself.
Okay, sir.
So combining both, I'll just like to share my screen. Yeah, it's not there. Sorry. Is it visible?
Yes,
Yes,
sir.
sir. The tonsillectomy thing is there, sir.
Okay, right. So this, I don't know how many of you had the opportunity to why we need fetal monitors. This is the news item in today's Times of India. Doctors declare baby dead in womb. Woman delivers a boy hours later. Okay. This is the news item in today, fifth. I put the date wrongly. It is today's news item. And most important monitor is proper history taking and thorough clinical examination. Okay. So in a place called Almora, they have said your baby is dead and we cannot deliver because of the stillborn. And then she was taken in the ambulance. When after traveling about 2 kilometers, the woman gave birth to a healthy baby to the sheer joy of everyone inside the emergency vehicle itself. So what the doctor said cannot be managed in a hospital. She delivered beautifully inside an emergency vehicle. Okay. The legs of the child had partly come out of the mother's womb. They were blue. In that moment, a doctor on duty found that the child did not have a heartbeat. The newborn was not declared dead in the hospital. We only expressed such a possibility. So they have tried to escape from the blame by saying this. So this news item in this modern day indicates that we have to monitor the babies very carefully. So what are the aims of fetal monitoring? Assessment of fetal well-being, especially in high-risk mothers. Mother with diabetes, mother with hypertension, mother with preeclampsia. In those, the fetal monitoring has a very important role to play. And it is also required for assessing how fast the fetus is growing, whether it is growing normally or is there an intrauterine growth retardation. Then identification of any fetal abnormalities, whether there is an anencephaly or any severe cardiac ailment, then you can consider termination at the very early stage itself. That is also coming under fetal monitoring. And determination of gestational period. Some patients, they lose track of the last menstrual period, so they don't know. So, sometimes in multiparous women it happens. So by assessing the gestational growth of the child also, and to ensure a safe delivery based on the presentation, whether it is a breech presentation or whether any cephalopelvic disproportion, all these things can be safely managed if you know the fetal, we have done the fetal monitoring. So fetal monitoring has to be classified into two categories, antenatal monitoring and labor monitoring. So this is the very first important classification you have to say. If they say fetal monitoring intrapartum, then you can go for all the tests what Sanjeev Raju has described. But if the wording is simple fetal monitoring, then better to classify it into antepartum monitoring and labor monitoring. Then
Okay,
coming to individual, the antepartum weight gain is the most important simple method of identifying the fetal welfare. Okay, clinical sign, weight gain, cheap and simple method. Just using a weighing scale, you can find out. Mother should gain at least 0.5 kg per week during the second and early third trimester. Then the rate of weight gain is plateaus off. Decrease possibilities if there is IUGR, persistent nausea, vomiting, or forced dieting. And increase in weight can happen because of PAH, renal disease, and polyhydramnios. Then symphysiofundal height. So the at least 2 times weekly, the mother's abdomen should be examined to measure the height between the symphysis pubis and the fundus of the uterus. So the centimeters should be roughly correspond to the period of gestation. So this height will increase in polyhydramnios. It will be smaller in oligohydramnios. So this is the second simplest method of identifying the fetal monitoring. Then fetal kick chart, they should come in the antepartum period itself. Okay. So the count of 10, start at 9 a.m. every morning, record the time taken for baby to move 10 times. Normal fetal activity, little variation in time taken. Decreased fetal activity causes delay in time taken. So benefit is detection of fetal compromise, more easier and cheap. And limitation is maternal anxiety. She may miss to count 1 or 2 and say it moved only 4 times or 5 times. It would have actually moved 8 times or 9 times. And it's a crude guide and sometimes inconsistent. That is the only disadvantage. But otherwise, you always ask the antenatal mother, is the baby moving all right? Then diagnostic ultrasound. This is the next important cheapest method of fetal monitoring. A two-dimensional map of uterus, 12 weeks. You can use a transvaginal transducer to find out the size. And more than 12 weeks, you can go for abdominal transducer to find out the various changes. Disadvantages are the bioeffects on cells and inducing heating. Whereas the other diagnostic ultrasound, what normally we do is for age assessment and find out any early problems. With the fetus, we measure the size of the fetus, growth, anatomy, everything we see. Then we can also locate the placenta and morphology. And we always assess the amniotic fluid and umbilical cord abnormalities, whether it is a cord around the neck or it is in normal position. So this that is why normally we do fetal measurements like this with the ultrasound, serial ultrasound measurement of the fetus, crown to rump health is the one, and then we do the biparietal diameter and head circumference, femur length, and abdominal circumference. So 4 things are measured in the fetal measurement. One is the crown CR length. The second is BPD and HC, femur length and abdominal circumference. These 4 things will tell you whether the fetus is normal size or not, or any problem is there. So the ultrasound picture of crown to rump length is measured like this, starting from the head. This is the head portion. This is the gluteal region. This is the limb bud. So the measurement is taken from the top of the head to the gluteal tip. So this is what is called the crown to rump length. And the head size is measured like this. Biparietal diameter and head circumference both are measured. And then this is the femur length measurement. We have marked the femur here and the abdominal circumference. So remember, these 4 points are the indicators of a normal growth of a child. So if there is a retardation or any abnormality, that can be easily monitored in the antenatal period itself. Then gestational age also can be done using all these parameters. And fetal symmetry. You can, with the head circumference, you can find out hydrocephalus or whether it is a microcephaly in the womb itself. And then femur length will show about achondroplasia. And the abdominal circumference, diabetic pregnant woman, macrosomia, it will be increased. Whereas in tripody and trisomy, it will be decreased. So these 4 measurements give a lot of clue on the welfare of the fetus. The other conditions are amniotic fluid scan, which is called amniotic fluid index. If it is less than 2 centimeters, oligohydramnios, more than 7, polyhydramnios. So the range should be between 2 and 7. So less than 2, oligo, more than 7, poly. Then umbilical cord scan with a color Doppler, you can see where it is positioned and whether it is causing any fetal distress by constriction or not. And you can do some invasive procedures like amniocentesis, chorion villus sampling, chordosynthesis. These are all very not commonly used because they are all done mainly when you suspect some congenital anomaly because of the history running in the family. And then the aim of routine ultrasound for the mother is the early scan is done between 11 to 14 weeks. This first confirms whether the fetus is viable or not. Sometimes you may be having a fetus, but the heartbeat may not be there. Then you can assess the expected date of delivery. You can also find out whether it is a single fetus or multiple fetus, and whether any gross abnormality like anencephaly or cardiomegaly, all these things can be done at the early scan, which we call it as the anomaly scan, or in the nowadays terminology. Then mid-pregnancy scan between 18 to 22 weeks. Again, the same thing plus the placental fixation, because after 20 weeks only the placenta completely gets fixed. So that is why the PAH all happen after that. And amniotic fluid measurement index is also very important. Then third pregnancy scan is done after 22 weeks, which is mainly to assess the fetal growth and fetal well-being. Now, if ultrasound is not very contributory, then you go for a MRI, which can tell you about things which cannot be diagnosed with the ultrasound because of, especially in obese women, ultrasound may not be a good tool to find out the defects. So there you go for MRI scanning. And amniotic fluid index is the one which is Leica volume, reflects the placental size and placental function and fetal metabolism. The sum of all these things, they measure it in 4 quadrants. That is the 2 hypochondric and the 2 iliac fossa. Both the size, so 4 quadrant measurement is done, and then you find out again, as I said, the presence of oligo or polyhydramnios. Then coming to the Doppler ultrasound, measuring the blood velocity in the umbilical artery, recorded in waveform pattern. Systolic blood flow velocity speeds up and diastolic blood flow velocity slow down depending on the amount of resistance in arterial blood. So as the pregnancy advances, this diastolic resistance comes down, as Sanjeev said. And this is another waveform measured through the Doppler usage in the umbilical artery itself. Then cardiotocograph. This is another important thing. I think you never mentioned about this wording, even though you mentioned about the biophysical profile. This is also mainly done using this instrument. So these are the baseline variabilities which will happen. That is, there should be a correlation between the uterine. This comes to monitoring during intrapartum. So all
Yes, sir.
what I have been telling earlier is all for the antepartum or the antenatal period. So intrapartum only you start measuring all the non-stress tests, stress test, biophysical profile, all these things come only for the intrapartum when some amount of contraction or late pregnancy happens. So this is the picture where you will find it is recording the heartbeat of the fetus, fetal heart rate estimation. Normally it is between 120 to 140 or 150. So it is normal. Then if it goes above 160, it is considered bradycardia, or less it is considered tachy and brady. So when there is a uterine contraction happening, it should either get decelerated or accelerated. Two things can happen. So this is one of the picture that is there to show how it is drawn or recorded. And the heart rate increases 15 beats per minute lasting 15 seconds. So within this is measured with the cardiotocograph. So this instrument is important for that. Within 20 to 30 minutes CTG, 2 or more accelerations per present defined as a reactive trace. The importance is it indicates fetal hypoxia. So if it is not, if it is having this tachycardia, that means the child is trying to maintain by increasing the heart rate. Whereas if the heart rate goes down, FHR deceleration, transient reduction, again run rate of 15 lasting more than 15 seconds. There are two types. One is called the type 1 deceleration, second is type 2, then there is a variable. So type 1 is called early, type 2 is called late, and third is the variable deceleration. So this is sometimes asked in the exam as a short note question. What are the various heart rate variations that can happen during labor? So that is the answer for this.
Okay.
So this is how the graph will be recording it. Type 1 or early deceleration, where the bottom curve is the uterine contraction. So whenever there is a uterine contraction happening, you find the heart rate is dipping here. And that heart rate reduction corresponds to the duration of the uterus contracting. Okay, if that is happening, it is mainly not because of the intracranial pressure, it is a scalp compression. So scalp compression at the lower uterine segment, that is what is calling a decrease in the heart rate. So this is the picture, if you can easily remember how it corresponds with the uh, uterine contraction. Then type 2, here you see the uterus has already started contracting. This black arrow is showing that it is contracting and trying to relax. But the heart rate dipping is continuing even beyond that. After the uterus contraction is over and it is started to relax, the heart rate decrease is still continuing. This is called the late deceleration. This is an indicator of persistent hypoxia, and the variable is will be both occurring in between. I think there is another picture that. So meconium stain liquor. Uh, so in the variable, it doesn't correlate to both the duration and depth of contraction. So it keeps varying, either decreasing or increasing. It doesn't correlate exactly with the contraction. That is why it's called the variable deceleration. So if there is a color change in the meconium of the liquor, which is normally about straw colored, if it becomes blackish or tar-like, that indicates that there is a meconium stain happening. And how is cardiotograph measured? It is a ultrasound transducer is there, which is placed in the fundus of the uterus, so that you can measure the contraction. And the other that is called the TOCO transducer to measure the uterine activity, and the ultrasound transducer to measure the heart rate. So that's why it's called cardiotocograph. Cardio to measure the heart rate of the fetus, toco to measure the, so we say tocolytic, isn't it? To the drugs which relax the uterus are called tocolytics. So when you measure or monitor the contraction, it is a tocometer or a tocodynamometer. And based on that only, we get this what is called the non-stress test and stress test. So when there is no uterine contraction and you measure the heart rate, then it's called the non-stress test. But in correlation with the uterine contraction, if you measure the heart rate, it is called the stress test. And these are all external method, non-invasive method of monitoring. Whereas there is another internal method of monitoring where you can insert a fetal scalp electrode to the scalp. Here it is attached, and intrauterine pressure catheter also can be used, and the same things can be measured. That is, you can measure the heart rate and you can use the contraction, but this is invasive. So majority of times we don't want to do that because of fear of infection and other things. And what are the features of a normal tracing? For heartbeat should be between 110 to 160. That is the baseline heart rate. Variability should be more than 5 beats per pulses per minute, and two accelerations more than 15 for more than 15 seconds every 20-minute period. And there should be normally no decelerations. These are all the things that we normally expect. With a normal cardiotocographic recording, is it useful or reassuring? Definitely it is reassuring, because a normal cardiotocographic tracing indicates that both the fetus and the mother contractions are all normal. And what are all the secondary tests which are done as what he said is vibroacoustic stimulation. You can just mention all these things as a name, and you need not to go into details of all these things. And
Okay.
how it is normal and abnormal, we are doing that. And fetal blood sampling is another method. This is an invasive method, but this is very useful to find out whether the child is having acidosis, whether it requires any immediate resuscitation as soon as it is born. All that can be found out by this. And coming to the last biophysical profile, between 30 to 70% of growth restricted fetuses with a non-reactive heart rate tracing require biophysical profile scoring to verify fetal well-being. And this was introduced by Gregory R. DeVore.
Okay.
And what do we do that in this? The patient should lie on the back with the belly exposed. A non-stress test measures baby's heart rate alone. So there is no uterine contraction. Then you put an ultrasound measure and baby's movements and breathing and amniotic fluid, all that is measured with an ultrasound probe. So it is a combination of the transducer which is available in cardiotocograph plus your ultrasound probe. And this is what you try to find out. This is what he said about the component and the definition. So the fetal movements, fetal tone, fetal breathing movement, amniotic fluid volume, and non-stress test, all these things are, 5 things are measured or observed in the biophysical profile. And this is the explanation for all that. And this is the scoring that you will get finally. So by measuring all these 4, you have a normal score of 2 or an abnormal score of 0. So if a patient gets, a baby comes under the category of 8 to 10 with a normal amniotic fluid level, that means the CSNs, no, both the central nervous system function and the oxygenation are both good for the baby. So it is not compromised. Whereas if you get a score of 6, that means it may be good or not, may not be good. So that's called equivocal. If it is for less than 4, it is definitely abnormal. And at less than 2, it is definitely will require intervention, as he rightly put it in. So that's all about the so if you write this much, of course, I didn't deal too much into the Doppler and all those things. What you
Yes, sir.
mention as a Doppler with a few points, if it's a short notes, you have to abridge all this into as much as possible and write a few lines on each of that. That will be more than enough. But mainly classify them into antepartum and intrapartum.
Yes, sir.
That is the first
Yes,
and foremost thing. And what are all the things that you can measure antepartum to assess the progress of the fetus? So that is comes under the fetal monitoring. About the growth, anomalies, all these things are monitored in the antepartum period. Intrapartum, about the safety of the fetus, whether it is advisable to allow normal labor to continue or whether you have to intervene. That is the idea with which you do the intrapartum monitoring. Okay, so
Okay,
that is what you.
Okay, sir. Okay, sir.
I think shall we stop here for today?
Especially when they do a labor analysis, sir.
Innama?
Intrapartum monitoring.
Mm-hmm.
Especially when we are involved in labor analysis, yes, sir.
Yeah, those who are in labor analysis, but I don't find many physicians using cardiotocograph. Many hospitals I have seen it is being bought and not used regularly in the mother at all. They go
No,
by.
sir. Because, OG centers have it, sir. They all have, sir, CTG.
Oh, they have, but how many times they apply and then they monitor? Do they do it
Soon after
routinely?
epidural, we put it continuously, sir.
Yeah.
Yes,
Maybe
sir.
you know better. I am not an obstetric anesthetist, so I have a few hospitals where I have gone and did some my very limited obstetric work early days. I have found that it lying in the corner, not being used at all. கேட்டாக்க license எல்லாம் வேண்டாங்கிறாங்க அப்படின்றாங்க. Maybe olden days they were not very keen. Nowadays maybe they are using it regularly. Kamachi?
Thank you, sir. Thank you. It was very good, very interesting part of the presentation, sir.
Plus,
And,
this fetal resuscitation, I think it will take another 1 hour to complete. So,
yes, sir. Can we have it for the next session, sir?
yeah, we'll have it next class.
Okay, sir. Thank you. Thank you, Dr. Sanjeev Raju. Thank you, Dr.
Thank you,
Mani.
sir.
Thank you,
Thank you, everyone.
Dr.
And
Sanjeev.
all
Thank you,
the
Dr.
candidates performed brilliantly today. I'm
They did
very
very well. That's
happy.
exactly what I want to say. They all did very well
They
today, sir.
did very, very, very well. And I hope the same trend and same tempo continues in preparation for the next classes also. Thank you very much.
Yes, sir.
Thank you,
Sir,
sir.
next week, what shall we have, sir, for the discussions in any case? You can
I will just let you know tomorrow.
Okay, sir. Okay. Thank you, sir. Thank you.
Okay,
Can I sign off this
Thank you,
meeting
sir.
today, sir?
Yeah,
Yes,
thank
sir.
you.
Thank you, sir.
Thank you, sir.
Thank you.